Welcome again to Medical Lynch Academy. Welcome to my YouTube channel. I hope you guys have been doing well. This is our second episode on hypertension and anti-hypertensive series. During our last episode, if you haven't watched, please you can go back and watch it. We looked on hypertension. We defined hypertension and also looked on how you can grade hypertension. We also looked at types of hypertension, that is the primary hypertension and secondary hypertension. After that, we looked on blood pressure, how we calculate the blood pressure and factors that affect blood pressure. So in the calculation of blood pressure, we said that the blood pressure equals the cardiac output multiply the systemic vascular resistance, also called the total peripheral resistance. Apart from that, also we looked on the formula of the cardiac output, where we said that the cardiac output equals the heart rate multiplied by the stroke volume. We looked at the factors that affect the heart rate and mentioned sympathetic activity and other physical activity that may have an influence on the heart rate. Apart from that, also, we looked on the stroke volume, whereby we said that the stroke volume equals the end diastolic volume minus the end systolic volume. We also looked at other parameters that may affect the stroke volume, and that is the preload and also the afterload. So if you haven't looked on that episode, please go back, check that episode, and once you grasp every detail of the concept that we explained in our last episode, then now you can be able to join this episode. So today we are going to continue from where we left on. Still, we are tackling the hypertension and anti-hypertensive series. Hypertension and anti-hypertensive series. So last episode we looked on hypertension. So today we're going to begin by looking on the drugs that are used to control hypertension. And that being said, this will be our second episode. Please let us begin. So we're going to look on our first group or first class of drugs that are used to control hypertension, and these drugs are called sympatholytics, or sometimes we can call them sympathetic antagonist. So please, if you have a pen and a book, a notebook, you can be ready so that we look on how we can tackle this group of drugs. So a brief introduction before we look on the drugs that have an impact on the sympathetic activity. We have first to understand what is sympathetic activity and how does it impact blood pressure. So an intro. So the sympathetic nervous system is a primary regulatory branch of the autonomic nervous system responsible for the rapid short-term adjustment of systemic blood pressure. I believe you guys, for those guys who have done physiology of the nervous system, we know that the nervous system is into two broad categories. That is the central nervous system, whereby you have the brain and the spinal cord, and also we have got the peripheral nervous system, which also has got other two classification. That is the somatic nervous system, which basically is the voluntary system, and also we have got the autonomic nervous system. So in the autonomic nervous system, we again have two broad category. That is the sympathetic nervous system and also the parasympathetic nervous system. So the sympathetic nervous system is always responsible for the flight and fright, and the parasympathetic nervous system is always for the rest and digest. So we're going to look on how sympathetic nervous system affect the blood pressure. Remember, during fright and flight, automatically we always have an elevation in blood pressure, an elevation in the heart rate. So today we are going to tackle first our understanding in the sympathetic nervous system, and once we understand how the sympathetic nervous system works, then it will be easier for us to understand the other system. So during acute stress, exercise, hypoxia, or hemorrhage, sympathetic activity surges, driving immediate increase in blood pressure through precise cellular and organ level mechanism. So we have got other parameters that sympathetic activity is involved. Number one, when one is stressed. During stress, there's always an activation of the sympathetic activity. Also during exercise, during hypoxia or during hemorrhage, sympathetic activity surges and this drives an immediate increase in blood pressure. So we're going to look how that occurs. So that being said, sympatholytics or sympathetic antagonists, these are a broad class of pharmacological agents that inhibit, block, or dampen the activity of the sympathetic nervous system. So these are the group of drugs that are used to dampen the activity of sympathetic nervous system. Remember, sympathetic activity leads to an increase in blood pressure, and if our aim is to decrease the blood pressure, then we have to go against the sympathetic activity. So the drugs that go against the sympathetic activity are called the sympatholytics or the sympathetic antagonists. I hope you're together till there. So a continuation, the sympathetic nervous system primarily utilizes the endogenous catecholamines, that is the norepinephrine and the epinephrine, to mediate the fight or flight response via adrenergic receptor. Remember, the SNS tends to use catecholamines. Catecholamines, these are the norepinephrine or the noradrenaline, and also the epinephrine or the adrenaline, to mediate the fight and flight. And these two catecholamines, they tends to attach themselves via the adrenergic receptors. And this, as you can see here, we put around 5 that are very common. We have got the alpha 1 receptor, the alpha 2 receptor, the beta 1 receptor, the beta 2 receptor, and the beta 3 receptor. So you have to know, one thing that you have to know, number one, is that these receptors are always located in different sites in the body. And you have to understand where they're located, because once you understand where these receptors are located, then it will be easy for you to understand the mechanism of action of these drugs. Yeah, so these drugs that are going to be used, number one, they antagonize these receptors, or they activate these receptors. There's some receptors here that when they are activated, they lead to a decrease in blood pressure. For instance, alpha 2 receptor, if you activate it, it leads to a decrease in blood pressure. But the rest, like alpha 1, you have to work against it. The beta 1 also. Beta 2 and beta 3 not so much, because they are located in other areas that have less impact on the blood pressure. So by disrupting this pathway, sympatholytics reduce the cardiac output. And we all know, if you reduce the cardiac output, you are decreasing the blood pressure. The same happens when you decrease the peripheral vascular resistance and alter smooth muscle tone throughout the body. So the major aim of these drugs is to disrupt this pathway, the sympathetic nervous system pathway. And once you disrupt that pathway, you will ultimately lead to a decrease in the blood pressure. So number one, we are going to look at some of the adrenergic receptors and their physiological impact. So this table here that I derived, you can see what I'm trying to explain. So we have a table here. This table has got 3 rows and 4 columns. Our first column will show us our types of receptor. Our second column shows the anatomical locations of these receptors. Our third column has our physiological impact of these receptors on various body organs. And our last column that I won't touch on, this shows examples of those drugs that work against those receptors, or that work in relation to those receptors. So our first row here, and in our second row, we have got alpha 1. So alpha 1 receptors, they're always found on the vascular smooth muscle. Yeah, and their impact on vascular smooth muscle is always vasoconstriction. So apart from being located on vascular smooth muscle, they may also be found in the radial muscles of the eye, and also on the sphincters that are found in the GI and the urinary bladder, and also on the prostate. But for this class, or for this episode, we are going to narrow down on the vascular smooth muscle, because the impact of these receptors on the vascular smooth muscles is the reason why the blood pressure tends to increase. So alpha 1 receptor, if you see alpha 1 receptor, think of the vascular smooth muscle. And what happens if you activate this receptor? They tend to cause vasoconstriction, and vasoconstriction leads to an increase of the systemic vascular resistance, and finally an increase of the blood pressure. So just ignore our last column here, because I'm going to dig deep on the drugs that tend to do that. So our last row here, you've got alpha 2. If you see alpha 2, think of the central vasomotor center, the brainstem. And also they can be found on the presynaptic nerve terminals. Apart from that, also they may be found on the platelets and the pancreatic beta cells. But for this class, let's just focus on the central vasomotor center and maybe the presynaptic nerve terminals. So for alpha 2, think of the central vasomotor center. So what are the impacts? So alpha 2, they tend to they lead to inhibition of the norepinephrine release via the negative feedback loop. And apart from that, also they also decrease the central sympathetic outflow. So these two sections here have got an impact on the blood pressure. So unlike the alpha 1, alpha 2 work against the sympathetic activity. Why? They inhibit the release of the norepinephrine. Remember, norepinephrine is an example of catecholamines that tend to lead or cause an increase in the blood pressure. So this alpha 2, they lead to, they inhibit alpha 2. Alpha 2 receptors, they inhibit the release of the norepinephrine. Yeah. So that being said, alpha 2 agonist or alpha 2 drugs, alpha 2 agonist, the drugs that promote alpha 2 activity will lead to a decrease in blood pressure. Yeah, so that's something that you have to understand. This is unlike the alpha 1. For alpha 1, we have to look, you have to focus on the antagonist, because alpha 1 antagonists are the ones that will lead to a decrease in blood pressure. Alpha 1 agonist will lead to an increase in blood pressure, because alpha 1 leads to vasoconstriction. So for us to decrease blood pressure, we have to go against vasoconstriction or against alpha 1. So for this, we have to use alpha 1 antagonist. So for this table, alpha 1, we go for alpha 1 antagonist. For alpha 2, we go for alpha 2 agonist. I hope we are together. So for alpha 1, we have to go for the drugs that go against vasoconstriction. For alpha 2, we are going for drugs that promote the inhibition of norepinephrine release. So for this section here, for this column, let's just ignore it. I'm going to dig deep on the drugs that act via this route. So in our second table here, other receptors that other adrenergic receptors are the beta receptors. So same, very similar to the last, very similar to our previous table. We have got 4 columns and 4 rows. So here, our second row, we have got beta 1. So beta 1 are always located in the heart. This in the SA node, the AV node, or the myocardium. But they can also be found on the juxta glomerular cells that are found in the kidneys. So beta 1, they have got impacts. The key physiological impact of beta 1, number 1, is the positive chronotropy. Positive chronotropy basically means an increase in the heart rate. Positive ionotropy, also this beta 1 leads to an increase in contractility, in the heart contractility. They also lead to positive dromotropy. Positive dromotropy stands for an increase in AV conduction speed. They also lead to an increase in renin release, and this happens when there's an elevation of blood pressure. So beta 1 activity tends to lead to a massive increase of blood pressure, number 1, through an increase in the heart rate. If you increase the heart rate, you are increasing the cardiac output and in turn increasing the blood pressure. Same happens when you increase the heart contractility, also the AV conduction speed, and also when you increase the renin. If you increase the renin release leads to activation of the RAS system, the renin aldosterone angiotensin system. We're going to look at this system on our next episode on how this system leads to an elevation of blood pressure. So we're going to look at the agonist antagonist later. So that's our beta 1. So beta 1 receptors, you have to have a clear understanding, because this is one of the adrenergic receptors that tends to lead to an increase in blood pressure. So this is the major culprit when it comes to increasing our blood pressure. So the beta 1 antagonists or the beta 1 blockers are some of the drugs that are used in controlling or decreasing our blood pressure. For beta 2 receptors, they're majorly found on the bronchial smooth muscle. So let me just highlight something clear. For this table, I want you to have a clear understanding on what I'm trying to explain. Let me highlight with red. So here, for beta 1, please remember that this is found in the heart. Yeah. And for beta 2, remember this is majorly found on the bronchial smooth muscle. So don't forget that. Yeah. Beta 2 majorly found on the bronchial smooth muscle, but they can also be found in the uterine smooth muscle, the liver, and skeletal muscle. And one of the major thing of beta 2 is that it leads to bronchodilation. It opens the airway, allowing someone to breathe well. So it leads to bronchodilation. Beta 2 leads to bronchodilation. Apart from that, it may also cause uterine relaxation, that is tocolysis. It may also lead to glycogenolysis, the breakdown of glycogen, and also gluconeogenesis. The making up the manufacture of new glucose, gluconeogenesis. These two may lead to an elevation of blood glucose level. So remember, for the beta 2 adrenergic receptors, so beta 2 antagonist may have a large impact on the bronchial smooth muscle. They may cause bronchoconstriction. So that's something that you have to understand. But beta 2 agonists, the drug like salbutamol, they're very good drugs because they bronchodilate. They lead to the dilation of the bronchus, and they're always used for asthma. Yeah, so don't forget that. But antagonists, very dangerous because they may lead to bronchoconstriction. That's why they're always contraindicated in asthma or COPD. Beta 3, rarely mentioned, they're always found in adipose tissue or the detrusor muscle, and they may lead to lipolysis, which is the breakdown of fats, and also in the detrusor muscle they may lead to an increase in bladder capacity. So example of the agonist drug that is always used is the mirabegron drug, which is always used in overactive bladder. This is a condition that you're going to look when you do medical surgical nursing. So that being mentioned, so for this table, I want you to understand two major key areas. Number one, beta 1 found in the heart, and it leads to an increased heart rate, increased heart contractility, and also increases the AV conduction speed. And apart from that, also it may be found on the juxtaglomerular cells, whereby it leads to a release of renin. For beta 2, remember that it's always found on the bronchial smooth muscle, and when you promote beta 2 receptor, you may cause bronchodilation. But anything that goes against beta 2 may lead to bronchoconstriction, and that's the reason why beta 2 antagonists are always contraindicated when it comes to COPD or asthma. I hope till there we have a clear understanding. So let's continue with our session. So this table here is what I was trying to explain. Let me just go back to my marker pen. So this is what I was trying to explain. This diagram here shows various location of the adrenergic receptors, both the beta adrenergic receptors and the alpha adrenergic receptors. So you can see what I was trying to explain on my previous slide. So for central regulation, the adrenergic receptors that are found here are the alpha 1, the alpha 1, the alpha 1. So the alpha 1 are the alpha 2. My bad, the alpha 2. So the alpha 2 adrenergic receptors are the ones that are found on the brainstem, yeah, on the central vasomotor centers. So those are the alpha 2 receptors. Then we know that the alpha 2 receptors here, they tend to inhibit the norepinephrine release, and that's something that you have to remember. And they also stop the sympathetic drive. Apart from that, we also have got other receptors. The beta 1 are found on the heart. The beta 1 adrenergic receptors are always found on the heart, and this one here, they lead to an increased heart rate, which is also positive chronotropy. They also cause an increased conduction velocity, that's also called a positive dromotropy. And apart from that, also they may lead to an increased contractility, that is positive inotropy. So for beta 1, remember beta 1 are found in the heart. Here we have our beta 1. Beta 1 are found on the heart, beta 1. So when it comes to vasculature or the smooth vasculature here you have to remember the receptors that are found here are the alpha 1 receptor, the alpha 1 adrenergic receptors, and they always lead to arterial vasoconstriction, narrowing diameter, and also they may lead to venoconstriction. Remember, the arterial vasoconstriction leads to an increase in the systemic vascular resistance, yeah, and this may lead to an increase in the blood pressure. Venoconstriction, this will lead to a venous return, and venous return may increase the preload. Remember, the preload tends to increase the end diastolic volume, and when you increase the end diastolic volume, you are increasing the stroke volume. If you increase the stroke volume, you're increasing the cardiac output, and if you increase the cardiac output, you're increasing the blood pressure. So that's something that you have to remember. But remember, in the smooth vascular muscles here, remember what we find there are the alpha 1 receptors, the alpha 1, sorry, the alpha 1. In the kidneys here, we also have the beta 1. This tends to lead to an increased renin secretion, and the increased renin secretion will lead to RAS activation, the renin, renin, aldosterone, angiotensin system activation. So down here, we've got a formula of the blood pressure, which equals the cardiac output multiplied by the total peripheral resistance. So all this diagram shows, so by understanding this diagram, you're understanding where, number one, where we find these adrenergic receptors and the response of these adrenergic receptors when it comes to blood pressure. So remember, the alpha 2 are found on the central, alpha 2 are found on the brainstem. Alpha 1 are found on the vessels, beta 1 are found on the heart, and beta 1 also are found on the kidneys, on the justa glomerular cells. The beta 2 are found uh, on the bronchial muscles, and beta 3 are found on the adipose tissue. Those two are not largely involved in blood pressure. So if you want to understand blood pressure, you have to understand the alpha 1, the alpha 2, and the beta 1. So that being mentioned, let's go now to classification of sympatholytics. So what are the sympatholytics? Now, sympatholytics are classified based on their anatomical site of action and the specific receptor subtypes they antagonize. So let's look at some of the classes of sympatholytics. So the first one here that you have are the centrally acting alpha 2 adrenergic agonist. We have got the beta adrenergic receptor antagonist. These are beta blockers. We have the alpha adrenergic receptor antagonist. So one thing before I continue, number 1, number 3 may be confusing for those guys who haven't watched my previous slides. So centrally acting alpha 2, this one are the agonists, because we want to promote alpha 2 activity. Alpha 2 activity work against sympathetic activity. That's why we want to promote it. Whereas number 3, it's antagonist. Yeah, the alpha 1 tends to lead to an increase in blood pressure. So if you want to decrease blood pressure, we have to work against the alpha 1 receptor. So point taken home, alpha 2 receptor, we want to promote it because it leads to a decrease in blood pressure. Alpha 1, we want to work against it because it leads to an increased blood pressure. So that's something that you have to remember. For alpha, may have those that are non-selective. These are those that work on alpha 1 and also alpha 2. The selective one, they only work on alpha 1. And lastly, we've got adrenergic neuron blockers, also called the presynaptic or depleting agents. So as you can see here, the first one now, let's begin with centrally acting alpha 2 adrenergic agonist. So remember, alpha 2 adrenergic receptors, they tend to promote sympatholytic activity. So you have to support it. So you have to look for the drugs that promote alpha 2 agonist. And remember, they are always located centrally in the central nervous system. So the first point here is that they inhibit the sympathetic outflow from the central nervous system. And by doing this, they will be decreasing the blood pressure. Remember, the sympathetic outflow leads to an increased blood pressure. So if you inhibit sympathetic outflow, it means that you're decreasing the blood pressure. So brief explanation on the mechanism of action is that the presynaptic alpha 2 receptors serve as inhibitory autoreceptors. So their activation triggers a negative feedback loop that suppresses the endogenous norepinephrine and decreases sympathetic outflow to the heart and peripheral vasculature. So from this point here, what you have to understand is that the alpha 2 receptors, number 1, they suppress the endogenous release of norepinephrine, and also they decrease the sympathetic outflow. And by doing that, they will be decreasing the heart rate and decreasing the blood pressure. So the drugs that do this, they cross the blood-brain barrier and selectively stimulate presynaptic alpha 2 receptors in the vasomotor centers in the brainstem. So our main aim here is to stimulate the alpha 2 receptors. Yeah, by stimulating alpha 2 receptors, it means that you are going against the sympathetic nervous outflow, and that's what we want to do. Our major aim is to go against the sympathetic outflow, because when we do that, we will be decreasing the blood pressure. That's our major aim. So our continuation. So some of the drugs that do this, number 1, you have got the clonidine. Some of you guys have come across it or have used it. And also you have got methyl-dopa, which is very, very, very common. Another term that is known is aldomet. This drug is very common, especially in maternity wards, yeah, for those mothers who have got hypertension. You're going to see how they work and the mechanism of action and their side effects. So adverse effects of using this drug, number one, we know that they act centrally. That being said, they may cause CNS depression. CNS depression may lead to sedation, drowsiness, dizziness, and xerostomia. So they should be used cautiously for those guys who are driving, and it's best given when the client is resting or when the client is in bed rest. Apart from that, they may also cause rebound hypertensive crisis. That's another side effect when it comes to using these drugs, especially for those. The reason why it does that is because sudden withdrawal. If someone has got sudden withdrawal of clonidine, it may cause a massive unchecked surge of catecholamines, and when that happens, it may cause a hypertensive crisis. So that being said, if a client wants to stop using this drug, it must be tapered gradually. It may also lead to hemolytic anemia, and this is majorly associated with methyl-dopa. Yeah, this is majorly associated with methyl-dopa. Methyl-dopa can induce an autoimmune response. Yeah, and this response you can easily see, especially during a Coombs test, and this can be done when anemia develops. So let's begin with clonidine. So clonidine, number one, you should know, is highly potent and is available orally or via transdermal patches. So what happens, as I've explained, it binds to receptors on the synaptic terminals, the alpha-2 receptors, stimulate them. So the clonidine doesn't work against alpha-2. It promotes alpha-2. It stimulates alpha-2 because remember, we want to promote alpha-2. Alpha-2, when promoted, it decreases or it inhibits the sympathetic outflow. Yeah, so that's what we want to do. So these receptors are responsible for inhibiting norepinephrine from fusing on the cell membrane. So that's why we use these drugs. We want to promote alpha-2 receptor activity. So the end result here, this loses the sympathetic outflow, and this will lead to a decrease in blood pressure. So clonidine is an alpha-2 receptor agonist. Remember, it's an agonist, not antagonist. Alpha-2 receptor agonist. That's something that you have to remember. So it's not so much common, but it may be used for those clients who have got withdrawal symptoms, especially those guys who have got alcohol withdrawal or benzodiazepine withdrawal. So we know that during withdrawal, there's always a massive tachycardia. Tachycardia means an elevation of the heart rate, hypertension, and also vascular resistance. So that being mentioned, we need a drug that works against that, and that is clonidine. So one adverse effect, is sedation because it acts centrally, and that's about oral formulation. This is an oral formulation of clonidine. You may have come across it, especially for those guys who are under alcohol withdrawal, or for those guys under benzodiazepine withdrawal. They may those guys under alcohol withdrawal and benzodiazepine withdrawal, when they have got a massive withdrawal symptoms, they may be prescribed clonidine. So that's a drug that is being used. This is a clonidine picture, an oral formulation of clonidine, as you see in the diagram below. Let's continue. Next, we've got alpha-methyl-dopa. Now, alpha-methyl-dopa is a prodrug. It's always metabolized into alpha-methyl-norepinephrine in the central nervous system. When that happens, alpha-methyl-dopa works on the pathway that makes the norepinephrine. Remember, our major aim is to prevent the release of norepinephrine, because norepinephrine is an example of catecholamines that promotes the sympathetic activity. So our major aim is to prevent this from being released, and alpha-methyl-dopa works best when it comes to that. Remember, alpha-methyl-dopa is also known as aldomet. So it alters the synthesis of norepinephrine in the vesicle. That's another mechanism of action, and it's also very useful in pregnancy. So for pregnant women who have hypertension, so in hypertension in pregnancy, we see aldomet being used or methyl-dopa being used. It's a very good drug when it comes to controlling blood pressure in pregnancy. This oral formulation, it always comes into 50 milligram, always given maybe twice a day. Yeah, it can be given two doses, 500 milligram dosage twice a day, or depending on the physician order. So this is an example of the oral formulations of aldomet, as you can see in our diagram. I'm very sure those guys who have worked in maternity have come across it, especially when managing a client who have got preeclampsia, who have got high blood pressure in pregnancy. We have seen these drugs being used, the aldomet. Our second drug now, apart from the centrally acting alpha 2 adrenergic agonist, number 2, you've got the beta adrenergic receptor. These now are the antagonists. You want to work against the beta 1 receptors, especially the beta 1 receptors. You want to work against it. Now, they're also called beta blockers. So if you see beta blockers or the beta adrenergic receptor antagonists, they're more the same. They're just the same thing. So beta blockers antagonize catecholamine action on the heart, bronchioles, kidneys, and metabolic pathways, especially those that are non-selective. We know that the beta 1 are found on the heart, the beta 2 are found on the bronchioles. The beta 1 also can be found on the kidney, especially in the juxtaglomerular cells, and that they may have an impact on the metabolic pathways. Now, beta 1 are found on the cardiac tissue. For the beta 1 blockers may lead to negative chronotropy. Yeah, they may decrease the heart rate. They may also lead to negative inotropy. This means they may decrease the heart contractility. They may also have got a negative dromotropy. They decrease the AV node conduction velocity. Another thing that by doing this, this leads to a decreased cardiac output. If you decrease the heart rate, remember the cardiac output equals the heart rate multiplied by the stroke volume. So if you decrease the heart rate, you are decreasing the cardiac output, and if you decrease the cardiac output, you are decreasing the blood pressure. Also, since they decrease the heart contractility, they may decrease the myocardial oxygen demand. Yeah, so that's another thing that you have to know. They decrease the myocardial oxygen demand by having a negative inotropic effect. So beta 1 also are found in the renal tissue, especially in the juxtaglomerular cells. And this beta 1, we know beta 1 leads to an increase, a release of renin. So for beta 1 antagonists or beta 1 blockers, they prevent or they inhibit the release of the renin. And if you inhibit renin, you are basically inhibiting this renin angiotensin aldosterone system, because this system leads to an increase in blood pressure. Remember, don't forget our third episode. We're going to look on how this event occurs or how this event happens. So by doing that, this leads to a decrease in the downstream fluid retention and also vasoconstriction. Now let's look at the classification of these drugs. So beta 1 blockers, we have got 3 generations. We've got the first gen, second gen, and third gen. So the first gen, we also call them the non-selective ones. Now this one, they just work on any beta receptor. They work on both beta 1 and beta 2. Remember, beta 2 receptors are very crucial when it comes to bronchodilation. And when you act on beta 2, you'll be causing bronchoconstriction. So beta 1 are found in the heart, beta 2 are found on the bronchial airway. So, but example of these drugs are propranolol, timolol, and nadolol. Yeah. So they block beta 1, which are found on the cardiac tissue, and by doing that, they will decrease the heart rate, and by doing that, also they decrease the cardiac output and the blood pressure. And also they act on the beta 2, which are found on the bronchial airway, and by doing this they lead to bronchoconstriction. That's why a non-selective one, they're always used cautiously, especially for those clients who have got asthma and COPD, because despite decreasing blood pressure, they may also cause bronchoconstriction. So you have to be very cautious when it comes to using these drugs, especially for those clients who have got a history of asthma or history of COPD. Other thing that you have to know, you've got second gen. These are cardiaselective. These are good because they only act on beta 1 that are found on the heart. An example of these drugs are the metoprolol, the atenolol, the bisoprolol, and the esmolol. So they preferentially block cardiac beta 1 at standard doses, and they're good because they're not found. They don't act on beta 2, and and by doing that they minimize bronchoconstriction. Yeah. So the cardioselective ones, they don't act on beta 2. Yeah, and that's an advantage because they don't cause bronchoconstriction like the first gen. So the third gen, really, this one now that they're mixed, they both act on alpha 1 and beta 1. So the example of these drugs are the carvedilol and the labetalol. So these drugs, they remember they act on alpha 1 and beta 1. That being said, remember alpha 1 is found on the vascular muscles. Yeah. That being said, they've got a vasodilatory effect. Yeah. They lead to vasodilation. Yeah, they lead to vasodilation. So the combined alpha and beta blockade causes peripheral vasodilation while preserving cardiac protection. So these are our examples of beta blockers. The first gen or the non-selective beta blockers, the cardioselective beta blockers, and also the mixed alpha 1 and beta blockers. This is example of the number I've got now. This is the bisoprolol. This one is the cardioselective beta blocker. Very good. Only acts on the beta 1. And here I've got the carvedilol. This one acts on the beta 1 and also on the alpha 1. So that's something that you have to remember. So this one also has got a vasodilatory effect. It may also cause vasodilation because it acts on alpha 1 receptors. So what are the indications? Number one, we know these drugs are antihypertensives, so they are indicated for hypertension or high blood pressure. They may also be used on the chronic stable angina. Remember, these drugs, they decrease the myocardial workload or the myocardial oxygen demand by decreasing the heart, the contractility of the heart. They've got a negative inotropic effect, so they can be used for stable angina. They can be also used for cardiac arrhythmias. Remember, they've got a negative dromotrophic effect. They decrease the conduction speed via the AV node. And we know some of the arrhythmias, the atrial tachyarrhythmias, the likes of the atrial flutter, the likes of the atrial fibrillation, and also the SVT. So those arrhythmias, we can use the beta blockers. Yeah, they're very good drugs. When we look at antiarrhythmic medications in future, we know that the beta blockers are example of class 2 antiarrhythmic. Antiarrhythmic medications, they have got around 5 classes. You have got the class 1, the class 2, the class 3, the class 4, and the class 5. The class 1 are the sodium channel blockers, which we have got the class 1A, the class 1B, and the class 1C. That we're going to look later when we do antiarrhythmic medications. The class 2, now, these are the beta blockers, as you can see here. Class 3 are the potassium channel blockers. The class 4 are the calcium channel blockers, and the class 5 are the adenosine and the digoxin. So when you look at the antiarrhythmic, you're going to look at the beta blockers also. So remember, they are also used on the cardiac arrhythmias, the atrial flutter and the atrial fibrillation. They can also be used for stable heart failure with reduced ejection fraction, and lastly, they can also be used for post-myocardial infarction because they reduce remodeling and mortality. Now, the contraindications, remember the bronchospasm. This happens with the non-selective beta blockers, yeah, because they not only block the beta 1 that are found in the heart, but they also block the beta 2 that are found on the bronchial muscles. So by doing that, they may lead to bronchospasm. So that's why they're always used cautiously for those clients who have got asthma and COPD. So non-selective agents cause intense bronchoconstriction by the beta 2 blockade, and that being said, they're strictly contraindicated in asthma or COPD. So the drugs like propranolol, yeah, they are not good for those clients who have got asthma and COPD because they may lead to bronchospasm. They also block the beta 2. Another side effect is bradycardia and heart block. So they've got a negative dromotrophic effect. They slow down the conduction speed via the AV node. So this may lead to bradycardia and heart blocks. Yeah. So if you see a client is bradycardic, you may check the medical history, the drug history. Clients who are using beta blockers, they may also manifest with bradycardia. They slow down the heart rate. Yeah, they've got a negative chronotropic effect. Apart from that, also they mask hypoglycemia. For those clients who are diabetic, you should be very cautious when they are using beta blockers. Why? During hypoglycemia, we always have the sympathetic nervous system is always activated. During hypoglycemia, the client may manifest with increased heart rate. Some may have palpitations and tremors, and this always happens as a result of sympathetic outflow. So if you block the sympathetic outflow by the beta blockers, the client may not be aware that he or she is having hypoglycemia. So they mask the hypoglycemia, and the client may realize late when the hypoglycemia becomes severe. So you have to remember, when using this drug may mask hypoglycemia, especially for those clients who are diabetic. Don't forget that. So those are the 3 contraindications: bronchospasm, bradycardia, heart block, and massive hypoglycemia. There may be other side effects that you may look in your notes or on your textbooks, but don't forget these 3. Don't forget bronchospasm. For the non-selective ones, don't forget bradycardia, and don't forget these drugs mask hypoglycemia. Our third class of these drugs are the alpha adrenergic receptor antagonist. Now these one are the alpha. This one are the alpha 1 receptors. Alpha 1 receptors, don't forget, they're found on the venous and arterial smooth muscle cells. The venous and arterial smooth muscle cells contain the alpha 1 receptors. The alpha 2 receptors are found on the brainstem. Yeah, uh, don't forget that. So the alpha 1 receptors, they lead to vasoconstriction. So our major aim here is to antagonize the effect, yeah, to work against them. We want to work against the alpha 1 receptor. This is unlike our alpha 2. Alpha 2 receptors, we want to work with them. But for alpha 1, we want to work against them. Yeah, don't forget that. So when the arterial smooth muscle receptors are blocked, it makes the muscle to relax, causing vasodilation and dropping the vascular resistance and blood pressure. So when the arterial smooth muscles receptors are blocked, remember these receptors, they lead to vasoconstriction. Yeah. So our major aim is to block these receptors, and by doing that, we are going to cause vasodilation. And if you cause arterial vasodilation, it means you are going to decrease the systemic vascular resistance. And the same happens if you cause venodilation. Basically, it means you are decreasing the venous return. This decreases the preload, stroke volume, the cardiac output, and also the blood pressure. So when venous smooth muscle receptors are blocked, it makes the vein to relax, dilating, drops the preload, reducing cardiac output and blood pressure. I've just explained how that happens. So there are two types of alpha blockers. There are those that only impact the alpha 1 receptors on the venous and arterial smooth muscles. These are called the selective alpha adrenergic and antagonists. And there are those that act on both the alpha 1 and the alpha 2. So don't forget. So let's begin with selective alpha blockers. So the selective alpha 1 blockers, they competitively block the postsynaptic alpha 1 receptors on vascular smooth muscles. Yeah. So they block the alpha 1 receptors that are found on the arterial and the venous smooth muscle. So this inhibits the intracellular calcium influx, preventing smooth muscles contraction and resulting in profound arterial and venous vasodilation. So these drugs, they cause arterial dilation. This will lead to a decrease in the systemic vascular resistance and a decrease in blood pressure. Venous vasodilation, this will lead to a decrease in the venous return that will cause a decreased preload, which will cause a decrease in the stroke volume, a decrease in the cardiac output, and a decrease in the blood pressure. So I've explained this leads to a decreased systemic vascular resistance, especially when you block the alpha 1 that are found on the arterial smooth muscles. So as example of drugs that are selective, these are the prazosin, derazocin, doxazocin, and the tamsulosin. So how are they indicated? Number one, they're antihypertensive, so they're good for hypertension. They can be also used for benign prostatic hyperplasia, BPH, and the major drug being used here is the tamsulosin because it also relaxes the smooth muscles of the bladder, neck, and prostate capsule to improve the urine flow. So for tamsulosin, it's majorly used for those clients who have got BPH. So I'm certain you guys will be taught BPH in future when you do med-surg. You're going to be taught how this happens. So the reverse effects of these drugs, number one, we have got the severe orthostatic hypotension. That is something that tends to happen when using these drugs. Yeah, so you should be very, very cautious. That's why these drugs are always administered at bedtime. It may also cause reflex tachycardia, and also it may also cause fluid retention. You should know, for those guys, you should know the definition of severe of orthostatic hypotension. Please check on the definition of this. It's a decrease in it's always a decrease in blood pressure that happens when one changes a position, a sitting position. If you move from a sleeping position to a sitting position, there may be a decline in the blood pressure. So go and check on how this occurs and how this happens and how we manage orthostatic hypotension. So for selective alpha blockers, don't forget, number one, the adverse effects. Don't forget the indications and examples of the drugs that are being used. As you can see in the diagram here, we have got prazosin hydrochloride, example of the drug that acts as a selective alpha blocker. Continuation, let's move to non-selective alpha blockers. So for these drugs, they block both the alpha 1 and the alpha 2. So alpha 1 is postsynaptic, always found on the arterial and venous smooth muscles. And the presynaptic alpha 2, we know these are found on the central nervous system, on the brainstem. So alpha 2, so for this under this category, these drugs, number one, they block the alpha 1, and by blocking the alpha 1 they'll cause vasodilation. But one thing that we have to understand, they also block alpha 2. And remember, we don't want to block alpha 2 because alpha 2 it always work against the sympathetic outflow. So it means that the drugs that block alpha 2, they are promoting sympathetic outflow, but also causing vasodilation. That's something that you have to understand when it comes to these drugs. So blocking alpha 2 receptors destroys the negative feedback loop, causing a massive release of norepinephrine onto the heart, leading to severe reflex tachycardia. So that's something that you have to understand. So alpha 2 receptors destroy the negative. Number one, they have to know they destroy the negative feedback loop. Negative feedback loop is a loop that works against the sympathetic outflow. And when that happens, no, alpha 2 receptors blockers, they will go against that. Yeah. And when that happens, they'll cause a massive release of norepinephrine. There'll be a release of norepinephrine, massive release of norepinephrine. And this, we know, norepinephrine leads to an increased heart rate. So it may lead to a severe reflex tachycardia. So example of these drugs, number one is phenoxybenzamine and also phentolamine. They're also indicated for pheochromocytoma. So that's the major use or indication for these drugs. Yeah. So exclusively used in the management of pheochromocytoma, whereby catecholamine secreting adrenal tumor. So pheochromocytoma is an adrenal tumor that leads to massive release of catecholamines, the norepinephrine and the epinephrine. Yeah. So to prevent hypertensive crisis during surgical manipulation. So the major indications of this drug, think of pheochromocytoma. As you can see in my diagram here, they're always administered parenterally. You can see the phentolamine here, 5 milligram vial. Now, this is an example of a non-selective alpha blocker. It acts both on alpha 1, causing vasodilation, but it also acts against alpha 2 receptors, leading to a massive increase of or release of norepinephrine. So that's something that you have to understand when it comes to using these drugs. Now, let's move now to number 4, adrenergic neuron blockers. These drugs are very rare. I myself haven't come across these drugs. But if you've come across these drugs, please make sure that you comment on the comment section and tell us why you use those drugs and the indication of using those drugs. So these older agents do not block receptors. No, this one are not receptor blockers. This one, they just prevent the synthesis and the storage and the release of norepinephrine at the presynaptic terminal. So the first drug here is the risapine. This drug inhibits the vesicular monoamine transporter, preventing norepinephrine from being pumped into the synaptic vesicle. So this drug is they're not receptor blockers. They basically prevent the release of norepinephrine. And remember, norepinephrine is very crucial when it comes to sympathetic drive. So by preventing the release of norepinephrine, it means that it works against the sympathetic drive. So norepinephrine is left exposed in the cytoplasm, where it is destroyed by the mitochondrial monoamine oxidases, ultimately depleting the body's catecholamine stores. So this drug basically just its major mechanism of action is to prevent the release of norepinephrine, and by doing that, it will decrease the sympathetic drive, thereby decreasing the blood pressure. So these drugs are rarely used. Why? The reason why is because they not only deplete the norepinephrine release, but they also deplete the serotonin and dopamine, causing severe treatment-resistant depression and suicidal ideation. So they also they have an impact on serotonin and dopamine. And that being said, they're rarely used nowadays because of their impact on dopamine and serotonin. These two, they are very crucial neurotransmitters when it comes to understanding depression and also suicidal ideations. Another drug that falls under this category is the guanethidine. So this drug is transported into the nerve terminal via the norepinephrine transporter, where it concentrates in vesicles and physically displaces norepinephrine, preventing its release. So these drugs also it works against the release of norepinephrine. So these two drugs, the risapine and guanethidine, these drugs are not they don't act on the receptors. They basically prevent the release of the catecholamines, the norepinephrine. So I believe that's our end of our slide. Thank you guys for being patient with us. So that's a summary. We have looked on we have looked on sympatholytics or sympathetic antagonists. These are drugs that work against sympathetic activity, and you have mentioned 4 classes that fall under this category. The first class, you have looked at the drugs that work against the alpha 2, that work by supporting alpha 2 receptors. The alpha 2 receptors that are centrally located in the brain stems, and they work against sympathetic drive. Yeah. So the alpha 2 receptor agonist, the centrally acting adrenergic alpha 2 agonist, are good drugs when it comes to controlling blood pressure. An example of drugs that fall under that category are the clonidine and the methyl dopa. We have also looked on beta blockers, or the beta adrenergic receptor antagonist. And here you have looked on the 3 generations. The first generation, which are the non-selective ones that act on both beta 1 and beta 2, the likes of propranolol. And remember, on the non-selective ones, they may also lead to bronchoconstriction. So you have to be very cautious. The second gen are the cardioselective ones. They only act on the beta 1. These are the likes of the metoprolol, the atenolol, the bisoprolol. So these drugs, they only work on beta 1. And that being said, they don't lead to bronchoconstriction. And the last one are those that are mixed, combined. They act on both alpha and beta. And these are the likes of carvedilol. So don't forget those drugs that I've just mentioned. Apart from that beta blockers, you have also looked on those drugs that are alpha 1 receptor antagonist. Remember, alpha 1 are found on the arterial and venous smooth muscles. The major action is to cause vasoconstriction, and also by doing that, they lead to an increase in SVR. So the drugs that work against alpha 1 receptors, they lead to vasodilation. Don't forget, alpha 1 receptor blockers, they're also classified into 2. There are those that are selective and those that are non-selective. I have just explained. And the last class are those that are adrenergic neuron blockers, as you can see, the risapine and the gonantidine. Thank you for this session. I believe that you have a clear understanding of what we've discussed. If you're watching this video for the first time, please watch our previous video to have a clear understanding on what we have just discussed. If you have got any view that you have to add on this episode, please, you can comment on the comment section. If you've got anything that you have heard that you're not in line with, please let us know so that we can work on